You chairing the meeting, Raybridge?
By default, yes. Joe's going to be a little late.
Dr. Raybridge, did you receive the items I emailed you?
I did, yes. I have the
Okay.
agenda and the correspondence report and all that.
Okay.
I'll note that we are now live, or should I? So
Yes, yeah, we're live on live stream.
yes,
And we're
Very
recording.
good. So we will get started then. All right, so
whenever you're
this is the, yep, Marie, you want to start with the roll?
Yes, I will. Okay, this is the June 15th joint meeting of the New York City REMAC and Medical Standards meeting, and I will be calling attendance for both REMAC and Medical Standards. So your name may be called twice. Grace Cacciola.
Grace Catchiola's here. Thank you.
Thank you. Glenna Seda. Bradley Kaufman. Dario Gonzalez.
I'm here.
Nathan Reisman.
Here.
Pamela Lai.
Here.
Hi, Pam. Nick Alexandru.
Nick is here.
Doug Isaacs.
Here.
Kevin Ward.
Here.
Anne Marie Grigenti. Samia McEachin or Allison Burke. Jeffrey Raybridge.
I am here.
Reed Caldwell.
Here.
Oops. Lewis Marshall. Michael Redlener. Dominic Battinelli. Efran Rendon. Joseph Schenker's not here yet. Okay, Michael Vatch or Robert Ackerman.
Robert's here.
Joseph Bove. Sean Graves. I guess it's a nice day and nobody wants to come. Arthur Cooper. Robert Winchell. Okay. Ed Jarvis. Mark Cantor.
Here.
Sharice Berry. Where did I just put it next? Robert Krupe. Celia Quinn. Timothy Stiles. Laura Iavicoli.
Here.
Matthew Fink or Wallace Carter. Okay. Eric Cohen. Kevin Munjal. Cindy Basilios.
Kevin Manjal's here.
Thanks, Kevin. Cindy. Maria Bodick. Matthew Harris.
I'm here, Marie.
Thanks, Matthew. Jessica Van Voorhees. Ben Zabar.
I'm here, Zabar.
Thanks, Ben. Paul Barbara.
Present.
David Benelli. Thought I saw David. There he is.
I'm here. Thank you.
Thank you. Peter Wire.
Here.
Thank you. Yadidja Langsam.
Present.
Anthony Shalish. Okay. call Barbara. We're starting the medical standards attendance now.
Still present.
Cindy Basilios.
Here.
Okay, great. Joseph Bove. Neil Semolovic.
Here.
Wally Carter.
Murray, he just joined. He's
Yeah,
still.
I'm here. Sorry, I was on mute. Apologize.
That's okay. I knew you said you were going to be here.
Sorry.
Robert Krupe. Jeffrey Douglin or Lauren Kosturko. Thought I saw Lauren. Okay, and Reed Caldwell,
Here.
Jonathan Berkowitz,
Here.
David Lobel, Matt Freed or David Eng.
Matt
I'm
Friedman
present.
is on the line.
Dave Lobel's present also.
Okay, great, thanks.
We only want one of you.
That's it. Leave the room. Ed Jarvis. Okay. Jeff Raybridge.
Here.
Michael Redlener. Anthony Shalish. Rafael Torres. Jason Zimmerman. Nick Alexandru.
Here.
Glenna Seda. David Benelli.
Still here.
Okay, Dario Gonzalez.
Here.
Doug Isaacs.
Here.
Bradley Kaufman. Anne Marie Gregenti. Kevin Ward.
Here.
Thank you. Grace Cacciola.
Here.
Madeline Fong. Sean Graves. Robert Ackerman.
Here.
Morty Lax. Art Cooper. Yadidja Langsam.
Here. Marie, I'm here.
Thanks, Art. Yadidja? I know he was here before. Lewis Marshall.
Looks like he's still here.
Dr. Marshall? No? Okay. Kevin Munjal?
I'm having trouble with my system.
Okay.
Manjot here.
Jessica Vambarese? Okay, let me do a quick count.
Hi, Marie.
Yes?
I'm Brad Kaufman. I'm here for both. I've been muted. Having
Oh,
problems.
oh boy. Okay. Nobody wants you to talk.
Yeah.
Marie, it's Lydia. Do you hear me now?
Yes.
Okay.
Yes, we hear you now.
Okay, thank you.
I'm just counting to see if we have a quorum for medical standards, which I think we do one. Okay, we have a quorum for medical standards. And
All right, very good. We have a quorum for REMAC.
that's what I'm counting now.
Marie, it's Michael Redlener. I am here. I didn't respond verbally. I want to respond verbally now.
Okay,
Present.
Thank you for your verbal response, Michael.
Does that make him a V on the AVPU?
Yeah, I guess.
You just made the meeting longer. Thanks.
What else do you have to do, Paul? Come on.
hold on, I'm just counting. Yes, we have a quorum for REMAC also.
Excellent. All right, so first on the agenda is approval of the minutes. This is for the April 13th REMAC and Medical Standards meeting. The minutes were sent out. If there's any corrections, additions, changes. If not, is there anyone opposed to approving the minutes? All right. Correspondence report.
Do you want me to read it or?
Sure, go ahead.
Okay,
If you have it.
I should have it somewhere here. Okay, unless you want to do it, Dr. Benelli, that's fine.
Yeah, I have it also, whatever you know, whoever has it first. If you have it there, go ahead. Otherwise, I'll read it.
Okay, correspondence report. Membership, we received requests for medical standards at-large seats from Josh Buckland and Pesach Zirkin. I think we're going to be getting a few more. So hopefully our membership committee can work on this over the summer to seat some at-large members. We have about, this is for medical standards. We have about 7 at-large seats that are vacant, so we can fill them up. New York State Department of Health enforcement actions, there are a few. Keisha Brockington, EMT 239665, revoked effective May 21st from Staten Island. Sybil Frost, EMT 467382, suspended effective June 1st. Suspension stayed with a $2,000 civil penalty from Brooklyn. Joseph Oakes, I believe he's an EMT, 459149, suspended 1 year effective February 3rd. Suspension stayed, 3-year probation, $2,000 civil penalty from Edison, New Jersey. And Manisha Atkinson, EMT 450703, revoked effective June 3rd from Rosedale, New York. And there are 2 from outside of New York City. Robert Lukens from Saugerties, New York, revoked effective June 1st. And Brendan Booz from Rochester, New York, suspended for 1 year. And Maimonides Ambulance Agency has been approved as an ambulance transfusion service. And the council sent out the following correspondence, agendas, minutes, and associated attachments for these meetings. And that's the end of the correspondence report.
Very good. Thanks, Marie. All right, next on the agenda is elections. We have the current slate for REMAC is chair is Joseph Schenker, myself as first vice chair, Brad Kaufman as second vice chair. And then for medical standards, we have David Benelli for chair and Paul Barber for vice chair. There is no one else running for these positions. I believe we asked for nominations last time. Did you keep me honest here? Do I need to open it up to nominations for the floor right now before we vote, or we're good to go? We're good to go.
You can ask for nominations from the floor, and then you can move on.
All right. Are there any other nominations for any of these positions? Any nominations? And third time, any nominations from the floor? All right, hearing none. Nominations are closed. And we can vote on the current slate. And since all these positions are running unopposed, can we do them as a group?
You can direct the secretary to cast a single vote for all the candidates and be done with it.
All right. So
Actually,
direct the secretary. Go ahead, Marie.
We don't have a secretary on REMAC. We have a chair, vice chair, and second vice chair.
Okay, so you can just by acclamation accept them all instead of going through a roll call.
Okay.
So, okay, there you go. We are accepting all these positions as unopposed, and we will move on. Congratulations to all those suckers. I mean, people who are going to continue in their current roles for the next cycle. All right, the executive committee report. The executive. Thanks. The executive committee did not meet. Subcommittee reports. Medical standards. All yours, Dave.
So, thank you, everyone. Good evening. We met, I think, last time in April. We're going to start running through through the medical standards agenda, and then we'll pass it back to REMAC for further discussions. So we've done the correspondence report, so I think we can go to subcommittee reports. CNC, Paul.
CNC is meeting tomorrow, 9 o'clock via Zoom. Mr. Ward, would you like to discuss the exam or any issues?
No issues other than the ones we discussed in the previous meeting, which we'll discuss more tomorrow at CNC.
Mm-hmm. All are welcome to attend. It's an open meeting. Feel free to contact me or Kevin for the link. The REMAC exam is ongoing. The medical control exam is ongoing in its new format with some interesting findings. And I'm confident as the number of test takers increases, that we'll be able to clarify and improve the questions to tailor them to our protocols and the medicine delivered in our region. I think we have about 12 test takers since we went live with the online testing. Stay tuned. That concludes the CNC report.
Thank you very much. Thanks, Paul, from under the tropical waters. Oh, by the way, Marie, I see that Lou Marshall is here. I don't know if he was marked as present.
No, he wasn't. Dr. Marshall?
He is here.
Yeah, I'm here.
Okay, I'll update the attendance.
Okay, next, I'm going to keep the pleasure of the protocol committee for last. The interfacility tag. John, are you here? Can you give us an update?
Yeah, so our next meeting is July 8th and then August 12th. We've had a couple of offline meetings. The first topic to be discussed, remember, we have 6 subsections of essentially what are going to be standards that we're going to be endorsing. And the first section is essentially scope of practice and team composition, staffing and deployment. So I've talked with several people. Keith Herrera is taking a leadership role on this component. And we'll probably have something on paper for that July 8th meeting. We'll pass around ahead of time. I do have a request of the REMSCO. I wanted to know what folks feel is the best way to have some sort of an offline share site, whether it be Teams or Slack or Google or anything, but I'm hoping that we can have a place for folks to collaborate offline, because I think that there are a lot of good work that's done that way. So if there's anything that is endorsed by the REMSCO, I'm happy to use it. If not, I can always go, the old-fashioned Google way. Open to your thoughts.
Okay, very good. So the next meeting, I believe, is on July 8th, right?
That's correct.
Okay, thank you very much. The eCPR tag, the ECMO tag, met last Thursday after a delay of a week due to technical issues. As discussed, we have decided to start with a very small time-limited pilot in Manhattan, where there are readily available facilities who can accept eCPR patients. We sent out a questionnaire, a survey to the 5 identified hospitals. So far, we have received only a response from one hospital. The different tag members who were assigned to solicitate the responses from the other hospitals have approached again the hospitals, and hopefully we will get a clearer picture towards the next meeting. I do want to encourage all the tag members, there are supposed to be 12 or 14 tag members to attend the next meeting, which is going to be on July 8th at 5 p.m. That's the end of the ECMO tag report. Let's move on to the main part of this of medical centers, and that's the protocol committee report. So Dr. Lai, if you're ready.
Sure. Let me just, is it okay? Can someone please allow me to share the screen?
I'm sure Marie can do that. Maybe I can do that. I don't know. Hold on.
Oh, I got it now, I think.
Yeah, Charlie's
you should be
doing this
good
behind
now.
the scenes.
Oh, cool.
All right, thank you. And then David, is there a particular document you want me to start off with first?
Let's start with the appendices. I think we can run through them quicker. Again, we're going to review today, we're going to review the appendices and the GOP that have been in preparation for the updated unified protocols, also have been thoroughly combed through and reviewed at the protocol committee. And we're going to bring them here today for approval. Both the appendices and the GOP were sent in advance out to all the members for comments. So hopefully this should not take too much time. We are going to vote on the appendices as a bulk, and then on the GOP as a bulk. We're not going to vote on each section or appendix separately, unless Yedidia strongly thinks that it's inappropriate, just in the interest of time. Okay, so Dr. Lai, please proceed.
Okay, sure. So I will just kind of go through some of just the major highlights of the changes that were made to the appendix as well as for the GOP once we get to that section. So first off, just starting off with the telephone directory. So as you can see, obviously these references have all remained the same. The ones that have been removed, however, are the FDNY emergency medical dispatch as well as FDOC phone numbers were removed. As this was discussed during the protocol committee meeting, that this could be a potential security issues and things like that, so that obviously agencies will have access to these phone numbers, but these do not necessarily need to be readily made available onto our REMAC appendices, so that it was thought that it would be best if they would just be removed from here. But otherwise, this has not changed. Appendix B, universal approach to the EMS call. Again, this has largely not changed. The one change that was made on here was for the additional support resources. I believe that the medevac was removed from this section, just being from the New York City region, that was just removed, and just some language changes in terms of like additional pre-hospital providers, including all CFRs, EMTs, and paramedics were just included onto this section. Moving forward, the primary patient assessment. This was condensed just to include both adult and pediatric patients on here, but with just some definitions on the bottom that have not changed in terms of for the expected systolic blood pressure estimation for the pediatric patients as well as for the adult patients when there is a pulse that is palpable. So those definitions have remained the same on here, but otherwise everything that is in the tables has otherwise remained the same. Safety restraining devices. This was slightly modified just to include to have like some more, to provide more guidance and more direction for our pre-hospital providers. This is compliant with NHTSA as well as OSHA definitions in particular for the restraint of pediatric patients, that if ideally, if possible, that we should be using size-appropriate child restraint systems. But if these are not available, then it goes through just in terms of just some guidance to use if the pediatric patient's own safety seat is available to use, and in accordance to if the child is the patient versus if they are not the patient, in terms of just the appropriate restraints that are required just for the patient's safety. Moving forward, do not resuscitate and the MOLST sections. This is not changed. There is inclusion on here for the EMOLST as well as I believe that this is kind of being I think being pushed forward from the state as well as just for more of the occurrence of these out by our pre-hospital providers. So these are clearly marked on here. Otherwise, none of the content or any direction has not changed in this appendix. Glasgow Coma scale, we still include for the adult as well as for the infant Glasgow Coma scales. The one thing that has been removed from here is the trauma scores. Were not placed in here. Only the Glasgow Coma scores are included into this appendix. It was thought that if this is not something that is being put through by the notifications to the trauma centers, that this would be appropriate to remove from here and just include the Glasgow Coma scales on here. Trauma center criteria, again, has not changed. I think that this would be a future project for the protocol committee as well as for RTAC to potentially review to see that there would be like any changes that would be required from this, but otherwise this has remained the same. Burn center criteria has otherwise also largely remained the same as well. Hospital addresses, as well as sort of the, this has just been updated just to include, just as many of you all know, there are a lot of the hospital systems with some of the official names have kind of officially changed. So this was just kind of updated just to have the newest and most appropriate hospital names to be included on here. So we still have it with the boroughs as well as for Westchester and Nassau counties were also included in here. Skip through this. So then this is just the new Appendix H, so the specialty care facilities. This has now just been updated as well as to be included all in one table in terms of the capabilities for all of the hospitals that are in the New York City region, as well as some of the surrounding hospitals as well. Just it was thought that it would be easier just to have everything all into one table that is included on here. So all of these are up to date. I'm going to and are current, at least with what the information that we have for the 911 receiving facilities, as well as the ones that are not, but are concurrent with the FDNY dispatch information. So this is all current right now. Pediatric vital signs has remained the same. APGAR score has also remained the same on here. Modified start triage, the content has just been just slightly reorganized as well as slightly just reformatted on here, but otherwise in terms of the intent for the modified start triage, this has not changed at all. Just hopefully it is a little bit more clearer, especially with the inclusion of the color-coded table, as well as for the triage procedure as well. So hopefully it is a little bit more clear in terms of walking providers through the algorithm for this. Again, the inclusion of this flow chart, which has not changed. Tension pneumothorax neodecompression has not changed either. The CPAP appendix has also not changed. Inclusion/exclusion criteria have remained the same from last year. This is a new appendix here in terms of the vasopressor infusion rates via flow regulating devices. This was something that I think that, with the many vasopressor infusions that we do have included in our protocols, we have them included on here in terms of a flow rate mLs per hour. That is the common units that are designated on the flow regulating devices. Excuse me. So we have these for the vasopressors that we have in our protocols, as well as some common solution concentrations as well. We also have our NYC SLAN scale. The only change that was just made on here was just the exclusion criteria is now going to be greater than 24 hours, so that is current with our current protocols that were already passed. Otherwise, that has remained the same. This flow chart has also just remained the same, except for that 24-hour mark. the alternate destination patient inclusion exclusion criteria. The protocol committee understood that this is something that is a work in progress with many of the stakeholders within the region. And it was thought that while we understand that there are continually going to be a lot more changes in preparation for the true operationalization of this procedure, for now, we will just keep this the same until all of those stakeholders can meet again, and then so that we can revise both those sections for our GOP section as well as the appendix. So for now, these are going to be the same as what was included in last year's version of the appendix. This is just the inclusion of the vaccines protocol that we have, like for the influenza as well as for the COVID-19 vaccinations that was previously approved by REMAC and Cmac in December, but it's just now included into our appendix section. And then just the final section. So just after discussing this with Joe Schenker, so this is just sort of the inclusion of the remaining New York State materials that was requested of us to include in our appendices. But we just have the disclaimer that just because that there are some of these materials may be in conflict with some of our regional policies as well as some of our regional protocols, that these would just be sort of like used as sort of like an educational section. So whereas before, like in the appendix, I think they were kind of smattered in between like a few different appendices. This is now all included into one section at the end of our appendix section right now, with the disclaimer, as you can see there. But otherwise, that is just the New York State references that are on there with no changes really made to them besides just formatting changes. David?
Okay, very good. Any discussion, both from medical standards?
I have a question.
Go ahead.
So with regard to the systolic blood pressure estimates related to pulses, my understanding is that information is not supported by the literature. It overestimates and was removed from the 9th edition of ATLS. So I'm just, while we're updating these, I'm just curious if we should remove that or not, and would be curious to see what our trauma surgeons think about it.
Jeff, would you repeat that? I didn't quite hear what you said.
Yeah, so the systolic, the blood pressure estimates based on radial, femoral, carotid pulses, this kind of overestimates it. It's not accurate in a couple of studies that have been done, and my understanding is ATLS has actually removed this from the 9th edition. So I'm curious as to your thoughts on this, and are we perpetuating somewhat misleading information?
Like many of these things, the studies are not, shall we say, uniformly supportive. But at the same time, it's not entirely useless. I mean, if you feel a pulse that's pretty strong versus a pulse that's pretty weak, I mean, that may provide some help. But certainly, these numbers, these exact numbers are not going to be, perfectly accurate in every single patient. That's for sure.
Right. Yeah. So my thought is maybe we should say something like, radial pulse will disappear before carotid or femoral, or it just, I hate to have these numbers out there when we know that they're historically not reliable.
I kind of side with Art on this. We actually had this discussion during the protocol in the protocol committee. I raised exactly the same question, and it was kind of decided to keep it as the least worst of all options. That was the that was the rationale of keeping it rather than just completely removing it. I'm okay with removing it personally, but it's kind of gives you, as Art said, some sort of ballpark, and that's why we decided to leave it as is.
I think it's still in the curriculum for our EMTs and paramedics, and that was one of the deciding factors in keeping it at the protocol committee level.
I have a question.
Yes, go ahead.
In the age of automatic blood pressure cuffs, is this even a thing? For those who are providers who are on the call, is this even a thing? Do you have trouble getting a blood pressure with an automatic cuff?
Yeah, many times there's patients who have a low blood pressure. They don't read.
A low blood pressure. How low? Do we still need something that estimates an 80 systolic?
It's not an 80 systolic. It's more like as Jeff said, the radial will disappear before the femoral kind of thing, right?
I thought we killed this.
No,
I thought
so
we
too,
brought
but
this up and brought. I thought we had a discussion about this being out.
We did, and we decided to keep it, not to kill it.
Yeah.
Okay.
Well, I think if
I'm good
the
with both.
curriculum is behind, I think if the curriculum is behind and it's still in the curriculum, then we have to address it. But I just think it's old thinking, and we should. It sounds like
How
it was
about
considered, but
Yes, Paul.
Can I make an addendum or a suggestion? Something to the line of the literature does not support these numbers, and these are pure guesses only. Or something less inflammatory.
Yeah, we can't put language like that in the protocol.
I mean, we have to have a note saying that this is not real, because this is if the curriculum is old, it's our duty to have the medicine that's current in our protocols. We're not going to go back and change a curriculum. So we can address the fact that the curriculum is behind the data, and we can do the right thing by our providers to make sure that this is not something that they hold true in their hearts as gospel, but that this is a flawed system that we're all speaking of here.
So I think
if they're taught it in a class, they're going to hold it in their hearts as gospel, no matter what you write in your protocols. Okay, the curriculum is what's taught, and they remember that much more than they remember the protocol. I have to tell you that. So if it's wrong, it shouldn't be there completely, and you should be working on getting it out of the curriculum. But until you do that, I don't. Putting disclaimers and stuff makes us look very wishy-washy. We don't know what we're doing.
The other thing is, it says
Can I answer Dr. Langston?
Guys,
Can I answer Dr. I'd rather be wishy-washy than put something that's absolutely wrong.
Let's just remove
That's
it.
wrong.
I want to go by.
I'll pull the
order.
literature right now.
Guys, we don't need to pull the literature, Paul. Let's go by order. I think that Yoni Klein is next.
Absolutely. Yoni had his hand at the same time. Sorry.
Yeah, thank you for recognizing me. So,
Yoni
it still
Klein
exists
next.
within the curriculum. We discussed that at protocol. And the other component of this is, to answer Dr. Barbara, the argument of saying that they have automated blood pressure cuffs is because it's not a requirement for all level providers is really an unrealistic expectation that that's the answer. So that has to be taken into account because only our ALS providers are most likely to have access to an automated blood pressure cuff system, and our BLS providers predominantly do not.
I asked if they have the cuff. I didn't assume everyone had a cuff. We can record that. We can go back to the recording if we.
Okay, next is, thank you, Yoni. Next is going to be John Berkowitz, and I believe that then Jeff Ravage.
Yeah, I guess the risk of harm here that I'm concerned about is that someone's saying, oh, they have a radial, so they're not as sick as I think they are, and getting a false impression of someone who may be quite ill, because obviously we've all talked about the evidence. So but I also agree that you're right. People are gonna use the education, the curricula is going to end up having a bigger weight. But I think that at a minimum, we should all be in agreement that the risk here is that someone's going to a provider is going to underestimate a patient's severity of shock because they couldn't get an automatic BP measurement and they felt a radial and they said, oh well, they're just in the 80s. At least and then that's an issue, at least in my mind.
Next, Dr. Ravage.
Yeah,
And then
so
Dr.
in
Zeba.
thinking about this, I think we can come up with a compromise here. So what the literature does support is that radial always disappeared before femoral, then carotid, right? So if we rewrote it as, pulses, as patients become hypotensive, pulses disappear in the following order, and any patient with loss of a radial pulse should be considered to have profound hypotension. And just leave it at that and not put numbers. I think that kind of solves the issue, at least for now.
I like that.
Actually, that's true.
Agreed.
In adult patients, Jeff, right?
Yes, agreed. Sorry, Matt. Yep.
David? Hello?
Jeff, I think
lost
Art and
Matt.
Ben
Yes.
have their hands raised.
Did we lose David? Art, go ahead.
Yes,
I don't know what
I'm
David.
vice chair. You can check.
Sure, thanks.
Art, I
Just-
recognize Art Cooper.
Yeah, just FYI, I happen to have the HLS textbook close at hand, so I took a look at it. As has been reported, there is no mention of numbers in relation to, relation of specific numbers in terms of pulses and so forth, as listed in the protocols. At the present time, I think the statement that was just made that radial disappears before femoral disappears carotid is a good compromise. I might also say, though, that what HLS does really focus on is the fact that that blood pressure is not a really great surrogate for cardiac output, which is really what the whole thing is about. And and of course that's not something you can really put in the protocol. That's really much more of a teaching thing, as Yedidia already pointed out. But I think the compromise statement that was just mentioned, I think, is a good way to go for the moment. Thank you.
Thank you, Dr. Cooper. Dr. Zabar.
I'd like to start to, Dr. Zaber, 1 second. I'd like to start
you're
to wrap
back.
up. Yes, I am back. I'm sorry. I got cut off by a phone call. I'd like to start wrapping this up. So Dr. Zaber, I believe you're going to be the next person to discuss this. And then there's a motion on the table by Dr. Raybridge, which if there's a second to support it, then we will vote on that. Dr. Zaber, go ahead.
I don't know if the motion was to remove it, but I would remove it. I don't think we're required to have any sort of guidelines here about how to estimate blood pressure. So I'd make a motion instead of estimation of SVP under circulation, you just say evaluate for shock, and you just delete all these bullet points related to estimating blood pressure, because it's training, and I don't think we have to have something in here about how to do it. We can just delete it. That's my motion.
Dr. Alexandru, and that's it, guys. I don't want to continue anymore. Yes.
Yeah, I kind of agree with Ben and Yoni. I think if anything, we should just take it out. I think because just saying that the pulses disappear in different areas doesn't give you any kind of a reflection of what the blood pressure may be individually in different people. So why have it in there at all? To just rely or depend on getting a blood pressure or not and treating it appropriately.
Very good. So there's thank you very much, everyone. There's a motion on the table to remove this section that talks about the blood pressure estimation. Is there a second for that motion?
David, a question before we actually vote on this. Are we removing adult and pediatric, or just the adult section?
Good question.
I think it's just adult.
If I might just comment briefly on the pediatric section, okay? As we all know, it can be pretty difficult to get, an accurate pediatric blood pressure in the field, particularly if the cuff size is not quite right. While the expected SPP estimation is listed on the slide, is a reasonable estimate for the mean blood pressure in a child. It makes no mention of the lower limit of normal systolic pressure, which, as you know, is 70 plus 2 times the age and years. And I just, on the adult side, I just have to say that those of us that have attended NAMSP in recent years know that Dan Spade has spoken eloquently about the fact that, that all of these measurements are sort of on a bell curve, and, it's difficult to say that this is the exact cutoff. So I'll stop there.
Okay, so thank you. I think that maybe all this discussion should be kept for training, for teaching paramedics and EMTs, and should not be part of the part of a REMAC appendix. So I would suggest that we just remove this this whole section that seems to be controversial both for adults and for peds. Is there anyone who seconds this motion?
I'll second your motion.
I second.
Okay. Is there any further discussion about this? I think we already. Yes, go ahead.
And Dave, I'll just say to Art's point, it talks about blood pressure, minimum blood pressures, and the normal pediatric vital signs, Appendix I. So we already have that covered elsewhere.
Excellent point. Okay, if not, anyone from medical standards opposes or abstains from removing this part from the appendix? Okay, and we're going to vote on this as a whole. Anyone from REMAC opposes to removing this or abstains? Cool. Let's move on, Dr. Lai.
David, sorry, before we go on, the respiratory ethics thing, that seems very much like teaching as well. Is that something we want to leave or no?
Good question. Can you bring Pam? Can you bring it to the place where we're talking about?
Are you just referring to this section just right underneath? Right, just right here.
That's right. Yes, that's right. That's all I'm talking about. I'm not saying yes or no. I'm just asking.
Hey guys, it's Matt. Sorry to chirp in. Can I advocate just for a moment that, like, recognizing that most of this, I think we all agree, is education, teaching, but some of this is where a lot of providers go when they have a quick question about this, and the pediatric assessments is difficult. I agree with removing the blood pressure parameters because only a third of kids get a blood pressure taken anyway, and it's probably made up. I think these are good, subtle reminders of how to recognize a sick child, and I would advocate that there might be an opportunity to keep it in place. Just my personal thought.
Again, this is something that is a training, as you agree as well, Matt. This is something that is a training issue, and I'm convinced is being addressed elsewhere as well. Okay, any further discussion about this? Does anyone want to remove the respiratory effort assessment sentence over there, or is everyone comfortable with keeping it there?
I think anything that's teaching should be taken out. We have a robust training education, and we should be expecting the medical directors and the operational leadership to be teaching the crews.
Okay, so unless there's any further objections, we'll remove also this next sentence. Okay, thank you very much. Pam can finish going over all the appendices. Is there any further discussion about the appendices?
Yeah, David, I have just a question, or just something to bring up. Have we given any thought, either in protocol or at REMAC, about developing pediatrics trauma criteria the way we have adult, since the state has them and we do not?
Yeah, so Nick, so at least I can just discuss from the protocol committee standpoint. I think that is something that, again, will have to be something that we will kind of refer to our RTAC colleagues to see if there are some criteria that they would like to put forth. I think that will be like one of our projects for this coming fall time to discuss and develop, but that's just from what was discussed at the protocol committee. So I believe there are other people who will know more information.
David, if I might on this, this has been a relatively controversial issue at the state level. Not controversial in terms of content, but more in terms of process. The STAC has voted, and Cmac has, I believe, confirmed the notion that we should be using the national criteria that were put out by the CDC and the American College of Surgeons. The problem with those is that it's not explicit. Those criteria are not explicit in terms of saying where pediatric patients should be taken. And that's an issue that has yet to be resolved. Nobody is in disagreement about the content of the CDC/ACS field triage guidelines. Everybody agrees with their content. The issue has to do with what do you do with a pediatric patient who does not who meets major trauma criteria. The national /ACS guidelines basically say take to a pediatric trauma center if available, or language to that effect. Whereas the state criteria are much more explicit, saying you really have to go to a pediatric trauma center. That issue still has not been resolved after over 2 years of discussion. And I believe that it's kind of fallen off the radar, but it's something I think we need to bring back to the state. But I think that there is no question in terms of the thought process that we should be following the same, national CDC/ACS guidelines that everyone else is following across the country. Thank you.
Did David disappear again, or are you there? Doug,
I'm here. I'm here.
Oh, sorry.
I'm here talking to a muted microphone. So I guess this will be addressed in the future. Yes, go, Doug. 1 minute.
Yeah, hi. Sorry,
this will be addressed in the. I got it. I guess this will be addressed in the future by RTAC. Dr. Isaacs, Dr. Stiles, and then I would like to move on.
Okay. So I brought this up at the last RTAC meeting to address I think it was Nick, I think brought this issue. This is an ongoing issue that we don't have pediatric trauma center criteria. And I understand Art's point, but one of the things that's just the last RTAC that the pediatric trauma, I guess, kind of a tag from RTAC to help come up with some criteria, because we certainly can use them. So Art, I'm not sure if you're at the last RTAC meeting. Apologize if you are, but I did bring that up. So maybe I'll follow up with Jose, Prince, and then kind of reach out to all the pediatric folks like yourself, Art. So we can have that tag to work on some criteria.
Sure.
Thank you, Dr. Stiles. Tim?
Yeah, sorry. My question was actually about something later in the appendix. I don't know if I can go on to the next topic or not.
I believe that we're done with this discussion at the moment until we hear further from RTAC, so please go ahead.
Okay, just looking at the vaccinations section, starting on page 34, it does mention to be updated for additional vaccines as they come online. I do know that Johnson & Johnson was approved, so I don't know if that's the intention that it would be added. It's not currently in there. I just wanted to make reference to that. And then knowing that we'll have a couple other COVID vaccines come on as well, I don't know if that's going to need to be brought back every time one gets added, or does the statement at the very beginning on page 34 allow for additions?
Dr. Sly, Isaac?
Yes, I mean, I think that the intent for this was that this will be just sort of continually be updated as the vaccines become available. So in terms of for this iteration, for this version of the appendix, at least for now, we only just have the information here for the Moderna and the Pfizer. But then I think that, when we have our new meetings coming up in the fall, we will have to update with the new vaccines that are available.
Excellent. Thank you very much. It's almost 6 p.m. I'd like to put up all the appendices for vote, both by medical standards and REMAC. So is there anyone in medical standards who opposes or abstains from moving all the appendices for vote in REMAC as seconded motion? Okay, hearing none, Marie, let's do a roll call for REMAC to approve the appendices.
Okay, so we are voting to approve the GOP and the appendices with the one change of removing systolic BP estimation and respiratory effort. Correct? No other changes?
Correct.
Okay, please respond in favor, opposed, or abstain. Glenn Asada. Bradley Kaufman.
In favor.
Dario Gonzalez. Dr. Gonzalez?
He's here somewhere.
I know. It's probably muted. We'll come back to Dr. Gonzalez. Nathan Reisman?
Nathan is also here somewhere.
Yes, I'm here. Approved.
Okay. Pam Lai?
Yes, approve.
Nick Alexandru?
Yes, approve.
Doug Isaacs?
Approve.
Okay. Jeff Raybridge? Reed Caldwell?
Yes.
Lewis Marshall?
Yes.
Michael Redlener?
Approve.
Okay. Joseph Bove and Joseph Schenker are not present. Dr. Cooper?
Yes, approved.
Robert Winchell is not present. Mark Cantor? Dr. Cantor?
Approved.
Thank you. Robert Krupe?
Yes, approve.
Celia Quinn or Tim Stiles?
This is Tim, in favor.
Thank you. Laura Ivacoli?
Approve.
Wallace Carter?
Approve.
Great. Kevin Munjal?
Yes.
Cindy Basilios?
Approve.
Maria Bodick? Matthew Harris?
Approve.
Jessica Van Voorhees? Ben Zabar?
In favor.
Paul Barbara?
He left.
Oh, okay. Jonathan Berkowitz?
Approve.
David Benelli?
In favor.
And Peter Wire?
Yes.
Okay. It's unanimous, it carries.
Excellent. Okay, so let's move on, Dr. Lai, to the next big section for approval, and that's the GOPs. So again, we all received this in advance in the mail. The GOP sections have been discussed during two separate protocol committee meetings. And there was a lot that was hashed out over there. So hopefully we will not have much discussion over here. Dr. Lai, just please review the highlights, the changes. Thank you very much.
Sure. So for the most part, there were just a lot of organization as well as some language changes. I will again, just as with the appendix, I will go over like the highlights as to some of the big as to the major changes that did occur with the GOP section that were besides just the language in the organization section. So the first part that was changed on here, again, in terms of the section, we have like the definitions that otherwise remained unchanged, it's just in a new section. However, the big change that did come on in terms of the on-scene medical control for the physicians. This was discussed with Joe Schenker as well as discussed at the protocol committee in terms of the differentiation for REMAC OLMC certified physicians versus non-REMAC certified physicians in the cases where a physician is performing a procedure. Now for the REMAC certified physicians, if the procedures are within the scope of practice of the transporting pre-hospital providers, the physician does not need to accompany the patient. However, if the procedures are not within the scope of practice of the pre-hospital providers, the physician will then need to accompany the patient. This is in contrast to the non-REMAC certified physicians where for any procedures that are performed by the physician will then be required to accompany the patient. The thought process was that, again, like, you know, with the distinction between our REMAC and non-REMAC certified physicians, our REMAC certified physicians have an understanding in terms of the scope of practice, you know, of our pre-hospital providers, as well as sort of like their monitoring capabilities and so forth, that there is going to be that distinction for those physician performed procedures versus the non-REMAC certified physicians on here. The other section in terms of the big change will be, as I am coming down through here, will be through our transport decisions and procedures section. So again, so that you'll see for the delineation for the transport to the specialty care facilities, you'll see that for major trauma, that will have, so again, all these will be updated in terms of with the correct lettering for all the appendices. That will be my project to do in the next week or so. But again, for major trauma, so if the patient meets the trauma criteria as determined in the appendix, that patient, unless that patient has an unmanageable airway, they will be continuing transport to the trauma center. Burn patients, they will be transported as determined by the appendix, unless that they are in cardiac arrest, or that they are deemed to have an unmanageable airway, or if that patient meets trauma center criteria, or if there's activation of the New York City burn disaster plan that's there. Similarly, for stroke, that patient will be going to the appropriate stroke center, whether it be LVO versus primary stroke center, unless that patient's in cardiac arrest or they have an unmanageable airway, or if they meet trauma center criteria. And then the same for the STEMI as well, that they will be going to the STEMI center that was previously directed by telemetry, unless they have an unmanageable airway or if they meet trauma center criteria. If, however, that patient deteriorates into cardiac arrest during transport, the unit shall continue transport to the STEMI center as previously directed by telemetry. And again, I think that this is something that was much discussed over the past several years, just in terms of that hospital and that STEMI team already being prepared, having their cath lab as well as all their required personnel ready for that patient. Should that patient deteriorate, that it was thought that it was in the best needs for the patient to then keep transport to that already notified STEMI center. Next section, this is just a lot of language that was just kind of updated for the spinal precautions that are just, that I think that there was just kind of like removed in terms of like rapid takedown techniques and all those sort of things that were just removed. Otherwise, now we're moving on to the CPR section. These sections, in terms of the definitions, were made so that changes to these sections were made so that these changes, so that these definitions would be consistent with language that was already previously approved in the protocols for those respective sections. So you'll see that some of the language, especially some of the language regarding pediatric patients, has been updated to into these GOP sections as well. In terms of airway management, the change, one change that was made in terms of the airway monitoring is that the pulse oximetry was now mandatory for both ALS and BLS units. Again, this was thought that now in our COVID, during our COVID as well as in the future post-COVID periods, that this was something that was just instrumental in terms of treating and triaging a lot of these patients, and that because of those issues, that was thought that it would be mandatory for both ALS and BLS units on here. We've also included language that I think that is consistent with things that from the state in terms of non-invasive capnography that will be optional for monitoring patients' respiratory status, either due to a medical condition or for medication administration. Let's see here. Oral gastric tubes, it's just stated on here that after performing any advanced airway management, that providers may consider placement of an oral gastric tube. Let's see, this has otherwise remained the same in terms of medication administration and intravascular access. Vasopressin medication administration. So again, I know that we have discussed at length in terms of protocol committee, as well as some of the issues with available devices. We have now just gone back to our original language in terms of using the IV flow regulating devices, that all continuous vasopressin infusions must be administered using at least one of these devices. The next big change is going to be for the pediatric size estimation and the use of a length-based dosing device or a Broslow tape or another similar type of app type of device. Is that now it will be that any sort of length-based dosing device is now to be used only to estimate the weight, height, or size of equipment when treating pediatric patients. And then in terms of like any medication dosing, that these are providers are to follow our previously approved pre-hospital treatment protocols and not necessarily go to those the doses that are listed on the said like length-based dosing device. It was just thought, as well as sort of a discussion that was taking place during the protocol committee, that in crafting our protocols, we have referenced a lot of subject matter experts, as well as the current literature when crafting the dosages for a lot of these protocols, that these should be the ones that our providers should be using, as opposed to a length-based dosing device that we are not entirely sure a lot of times in terms of when that device was actually printed or when that device might be updated. So again, this is a change here in the GOP section. Definitions for shock, as well as for stable and unstable dysrhythmias, are again consistent with what has already language that has been made in our previously approved protocols. The next section is that in terms of big changes that were made is going to be in our section for the coordination of pre-hospital resources procedure. For this, that it was thought that it's just becoming more and more common, just in terms of our providers not really necessarily having any sort of guidelines in the region in terms of when they can, or even when they should, when there are different different levels of certification of providers when they are on scene. When is it going to be appropriate for a paramedic unit to transfer care to a BLS unit, or if they need to do a dual transport if needed to for a patient that may potentially be unstable. In terms of those sections, here in terms of there's a section now for the transfer of care between ALS and BLS providers that has been added on here in terms of guidelines that we have discussed at length at the protocol committee. Again, these are not protocols per se, but they are just guidelines for providers to use. Again, otherwise that we have the other things that have not changed include the definition for the MCIs. And again, just as before, the alternative treatment and alternative transport destination decisions. Again, this is something that has just been placed here without any changes made to this section. Again, understanding that that this will be coming further down the line when the true operation of this procedure comes into place for our region. And we'll make those appropriate changes with those stakeholders at that time. Mutual aid mobilization procedure, again, remained unchanged except for just a few minor language changes. And then the WMD procedure, again, has just remained here just as it has been unchanged before. So, David.
Very good. Thank you, Dr. Lai. I know a lot of work has been put into all of this. So any discussion regarding the GOP? Comments, questions? Very good. Again,
yeah,
I know that a lot of...
David, I think Ben actually has his hand up.
Okay. Again, I know that a lot of these discussions were held and a lot of questions were already addressed at protocol. So Ben, and afterwards, Tessa.
Yeah, if you can go back to the acute stroke, I'd just like to make a motion to add the definition of acute stroke as stroke-like symptoms of duration of less than 24 hours. I know in the appendix, it mentions that as part of the LVO criteria, but to make clear that even if there's LVO exclusion, an acute stroke is stroke-like symptoms. So it says exam findings indicate an acute stroke, and just in parentheses, symptoms with a duration of less than 24 hours. That's my motion to add that, to make that clear.
Makes sense. I second that. Before we get to Pesach, any further discussion about this? Anyone objects, opposes, suggests it wants to change it or not accept it?
And Dave, that's the intent of the stroke protocol, the appendix as well, right? It's not a change in meaning.
There's no change in meaning. Okay, very good. So Dr. Lai, you'll introduce that in there. And let's move on then to Pesach.
Hi, I just want to clarify, is the intention of talking about the non-REMAC physician providing procedure on scene, that if a doctor who's not a REMAC physician assists with, say, starting an IV or bandaging a wound, something simple, something within our scope of practice, that they then are required to go along with the transport to the hospital?
Yeah, so I'm just going to go to that section right now. So then again, as you will see, for any procedures that are performed, whether or not that they are in the scope of practice or not by that pre-hospital provider, that they are to accompany that patient.
So at the scene of a car accident or whatever, we would tell them you can't do anything unless you're willing to go to the hospital. That's what we're basically saying.
Yes, that's pretty clear in there.
Yes.
Okay.
Any discussion about that? Any concerns? Anyone wants to change it? Good. Okay, any further discussion about any other section in the GOP?
David, can I comment on that a little bit more too?
Yes, go ahead.
On that same bullet point, maybe we can adjust it a little bit for any procedure performed by a non-REMAC online medical control certified physician that is within the scope of training of the paramedic, that is not in the scope of the paramedic, that would require accompanying the patient. Maybe that helps a little bit in clarifying.
No, it doesn't help a little bit, and that's been a standard for a long time, because once the physician doesn't go along, and he starts with all kinds of liability issues, who's in charge? If something goes wrong, who's going to be blamed? Okay, the paramedic who makes contact with the patient has to tell the physician, listen, now I am in charge. If you want to stay in charge, you're a physician, then you have to come along. If you're not willing to do the entire care from beginning to end, then
I'm on the phone.
Stop. And we've had this discussion for years and years and years. There's nothing new here.
This is Dario. I think one of the genesis, and I agree with what I just said, was that it also allowed us to verify that this was in fact a physician. I've been on a scene where a physician assisted with a trauma, it turned out to be a psychiatrist or somebody who really should not be doing it. And I think that was part of the genesis, and we had multiple events in the past, and that was really why it sort of started to come in.
Yeah, that's true. I want to remind Dr. that I remember cases we discussed where a podiatrist got down on the floor and said he's going to tube the patient. Okay, the last time he saw a tube was maybe 50 years before. So that was a very important point to give us the ability to tell the physicians, please, we can handle it. But you want to handle it, your license, come along.
Yeah, I think that this is just something that has just been discussed over the years, but I think that it's just now just clearly stated into our GOP section, and that's just the change that was there. David, you're on mute.
You would think that after so many months into COVID, I would figure this out already, but no. Yes, so this has been discussed and hashed out in protocol again and again and again, and this is the wording and language that we reach. It has also been discussed and addressed in previous years, and I think that most of us are comfortable with the way it's worded here right now. Any further discussion about this section or other sections of the GOP? Very good. Hearing none, let me see, no one else is raising their hand. Is there anyone in medical standards who opposes or abstains from moving this forward, a second in motion to REMAC for a roll call for approval? Okay, hearing none, Marie, please, is Marie back?
Yes, I am back.
Okay, very good.
So we're
let's do
voting
a
on
roll call.
approval of GOPs.
Yes, with the little amendment that the stroke definition that Ben introduced.
Okay, I'll get that amendment. Okay, once again, please answer in favor, opposed, or abstain. Bradley Kaufman,
In favor.
Dario Gonzalez,
In favor?
Nathan Reisman,
In favor.
Pamela Lai,
In favor.
Nick Alexandru,
In favor.
Doug Isaacs,
In favor.
Jeffrey Braybridge,
In-
Reed Caldwell,
In favor.
Lewis Marshall,
In favor.
Michael Redlener,
In
Dr.
favor.
Redlener.
Here.
In favor.
Thank you.
Sorry. In favor.
That's okay. Arthur Cooper,
In favor.
Mark Cantor,
In favor.
Robert Krupe,
In favor.
Timothy Stiles,
In favor.
Laura Ivacoli,
In favor.
Wallace Carter. I think Dr. Carter may have had to leave. Kevin Munjal. Dr.
Yes.
Munjal, thank you. Cindy Basilios,
In favor.
Matthew Harris, Dr. Harris, okay. And whoops. Benjamin Zabar,
In favor.
Paul Barbara, or Jonathan Berkowitz.
Paul had to leave, so it's going to be John.
In favor.
Thank you, Dr. Berkowitz. David Benelli
Yes.
and Peter Wire.
In favor.
Okay, it carries.
Okay, thank you very much. And again, thank you, Dr. Lai, from all of REMAC and Medical Standards for all the hard work and pain in creating these new unified protocols. I really think that they are really a big step forward in many ways and bringing us up to date with the current science. And I think it's all for the benefit of the region. So thank you very much for this monumental job.
Yeah, thank you for everyone's hard work.
Very good. Any new, any old business that we have in medical standards? I don't believe so. So is there any new business to discuss in medical standards that anyone wants to bring up? Okay, then I will conclude medical standards for the summer. We will adjourn for the summer. Hopefully we're going to have a meeting in September. We're still talking about the date, and stay tuned. Marie will come up with that date, and I'm going to turn it over to Jeff.
Thank you. So with everyone's permission, I'm going to go a little out of order. I'd like to go to the item of new business for the benefit of both medical standards members and REMAC members. Dr. Benelli has a presentation on the New York City stroke data thus far, which I think will be very interesting. So take it away.
Okay, thank you very much. I'm going to see how I share my screen. Let's see, share content. Oh, only the host can share. So I need to be made the host, Charlie, or co-host.
Yep, you're good. Try again.
Share the screen. Okay, start broadcast. Okay, let me see this. Oh, very good. Let me see. I'm sharing my screen. Pull it up. Starting. Okay, so very much in the last minute, we were able to compile 2-year data to celebrate the 2-year anniversary for the initiation of the LVO project, the New York City Stroke System of Care, the specialized with our specialized New York City SLAM's stroke scale. So it's actually a little bit more than 2 years. It's 2 years and the whole month of April as well. So all in all, the percentages have not changed much compared to the previous numbers that we presented for 16 months and for half a year and then 16 months. OLMC call volume, we had close to 3,000 calls for LVO for concern of severe stroke patients with an SLAMS score of 4 and greater. Out of those, about 2,000 were approved for transfer to a thrombectomy stroke center or to a center with a high level of neurological care. The rest, about 1,000 of them, were transported to a primary stroke center. The main reasons for transport to a primary stroke center from those that did call OLMC telemetry was the first one was an SLAMS score of 3 or less, or last known well of greater than 5, which is depicted here in the pie chart. Essentially, we can't affect much the SLAM score of 3 or less that contacted unnecessarily telemetry, but we can affect the last known well greater than 5 hours, and that is already manifested in our new protocol, and we'll discuss this towards the end of this short presentation. With regard to the outcomes, as we said, close to 2,000 patients were transported to thrombectomy stroke centers. Of those, about a little bit over 80% were actually had a stroke diagnosis of any type. About 1,139 of them had ischemic strokes. Of those ischemic strokes, 590 patients, which are 31% of the total, or essentially half of all those with stroke diagnosis, were found to have LVO, large vessel occlusion strokes. The rest had hemorrhagic strokes, TIAs, or there were a small percent that did not have exactly specified what they had. The main alternative diagnosis of strokes remains unchanged from our previous presentations. The highest one is seizures, followed by AMS, and then syncope, conversion disorder, encephalopathy, cancer, etc. Of those with LVO ischemic strokes, the 590 patients, thrombectomy was performed in 401 patients. The majority of the LVOs were not surprisingly identified in the MCA, the middle cerebral artery, with the clot successfully removed in the majority of them, 93% of them, 372 patients. Reasons for not performing stroke thrombectomy procedure on the LVO patients. This is as reported by the hospitals, and that's unfavorable. This is again unchanged from our previous presentation. Unfavorable brain imaging or hemorrhagic transformation. When the risks outweigh the benefits, significant improvement just after TPA, significant pre-stroke disability. There was no occlusion that was proximal enough and a large vessel large enough to access and remove. Sorry, 1 second. Here we are. Symptoms resolved or began to resolve without TPA even, unfavorable vascular anatomy or patient refusal, patient or family refusal. With regard to median transport times, this not significantly changed. The one that's really important for us is in the pre-hospital aspect of this systems of care. The time from en route to hospital is a little less than 8 minutes, and that's and that number has been consistent throughout over the past 2 years. When we look at on-scene time, on scene of EMS time to time for first pass, is slowly improving. If after 6 months it was almost 183 minutes, it's now 172 minutes, 173 minutes. So we are getting closer. There's still work to be done, but it is improving. The same thing goes from hospital arrival to first pass time. That also is gradually improving. This is a chart, a graph of New York City according to zip codes with the average travel time, where the blue color is essentially those that are under 10 minutes, which is quite a lot of New York City. There are very few that are 20 to 25 minutes transport times. And that is in those remote areas that we know are also hard to access from the point of view of STEMIs and trauma as well. And unfortunately, it's unchanged for stroke too. But all of the areas, all of the regions in New York City meet the less than 30-minute transport time to thrombectomy stroke center. So all of New York City is covered according to the AHA criteria, which is now probably up to 45 minutes. So we are well within the AHA guidelines. This is an interesting graph that talks about the difference in mileage traveled between the suggested primary stroke center to a thrombectomy stroke center. How much more do we have to travel in order to bring a patient from instead of to a primary stroke center to a thrombectomy stroke center where we can do the LVO? Again, the mean and the median is really low. It's 0.23 miles with a mean of 1 mile. And the 90th percentile of 3 miles. Again, this just is a good attestation to our success and to our ability to bring these patients in a timely fashion to a hospital where a procedure can be performed. This is a graph that we've been talking about. We still have providers who, for patients that have an SLM score of 4 and greater, still do not contact telemetry, and that dip started during COVID, and it's slowly recovering. There's a trending up, but this is something that we need to work on with our training to ensure that providers do contact telemetry to make sure that they're being taken to a thrombectomy center that has an operational cath lab, so that actually can undergo the procedure. Again, so if we go back and look at the numbers before I talk about the action items, there were close to 400 people who underwent a thrombectomy, if I remember correctly by the numbers. 400 people that 2 years ago would not have a thrombectomy performed, actually had their thrombectomy performed, with the majority of them had the clot removed. I think this is we changed the outcome and the lives of many of these patients that otherwise would have remained with much greater comorbidities. With regard to action items, so the first action item is to increase the last known well time window to 24 hours. And we have done that before we actually did this presentation, for the simple reason that we wanted it to get approved in the protocol, so it will be incorporated in the upcoming training for the new unified protocols that will come in effect on in 1/1/22. And during that training, we will need to reinforce the fact that OLMC must be contacted for any patients with New York SLMs score of 4 and greater. That's the end of my short presentation. I'm going to unshare the screen once I figure out how to do that.
Thank you, David. That was really great. We do want to keep the agenda moving, but I think we have time if anyone has like 1 or 2 questions about this. We can, if you'll entertain those.
Absolutely.
Any questions for David? All right. Well, thank you again for the data, or for Michael. Or Michael, or yeah, either of them. This is great work.
Thank you very much, everyone, for your time.
Thanks. All right. We will, getting back on the agenda, we'll move to the QI report. Dr. Redlener, you have a report?
Thanks. I apologize for the wind in the background. I'm in transit, but actually what David presented is actually a great segue into the quality meeting. I'm going to just kind of briefly talk about what we discussed at the last meeting. I wasn't there, so Pam and Joe led the charge. The main item on the agenda was the 2021 Quality Improvement Project, and it really is actually kind of the culmination of kind of the stroke and STEMI projects in New York City and the First Watch project, you know, the Quality Improvement Project to bring First Watch to all of our colleagues across the city. So we want to use the dashboard that's been created in First Watch as a way to kind of start to improve some of the work that we do around stroke and STEMI. So the aims of our project, and really what I hope we'll do, is use REMAC as a way to kind of propose solutions for improvement in the pre-hospital setting. So the three things that we'll look at are the on-scene times during suspected stroke calls. We want to look at the percentage of stroke calls in which a blood glucose level is obtained. And then also we want to look at the percentage of chest pain calls in which an ECG is obtained in less than 10 minutes. We're working on some of the details, and we'll definitely look for your for REMAC input on the specifics. But what we hope to do is that at our meeting tomorrow, at the quality improvement meeting tomorrow, is really kind of finalize the project aims for the region. And then as we go through the summer and into the fall, really come up with some ideas, hopefully work with the education committee and with everybody in the region, really to kind of come up with some ideas about how do we improve the care that we're providing as a region. Now, for those of you, for those agencies that are not on First Watch, you'll still be responsible for providing data, but you won't have the tool of First Watch. So you'll have to check in with the quality committee around how you're going to submit data in a similar format to what we expect. So more to come on this. We're going to try to finalize tomorrow at our meeting, and then we'll bring it back to the region for more discussion. Sam or Joe, did I miss anything?
No, Michael, that was pretty much it. Oh, I'm sorry, Joe. I was going to say, I think that we pretty much just pretty much discussed the QA project charter as you had already described, and unfortunately, we just sort of ran out of time that we weren't able to discuss any new agenda items that I'm sure that we will get to tomorrow. Great.
Yep, and honestly, if the other thing that we wanted to address is probably around membership of the committee, and just the kind of general organization we're working on to make it more streamlined. So anybody who's interested in joining the quality committee, let us know.
All right, thank you. Any questions for Dr. Redlener? All right, is there a training and ed committee report?
Hi, Morty is not able to be here today, but his only announcement was that he was hoping to work with the EMS Bureau of Training to create region-wide education once these protocols are approved. So we're hoping to work with fire department on this, and that's the end of the report.
Thank you. IFT we covered already, unless John, do you have anything else for interfacility?
All good.
Okay. RTAC. Anyone have an RTAC report?
I don't know if Dr. Berry is here.
I didn't see her, but I don't know. Doug, you attended RTAC. Is there anything you wanted to say, or?
I don't think we had an RTAC meeting since the last time we met. So okay. There's nothing new to report.
Well, I can give an update.
Okay.
Right now, there's Dr. Berry and Dr. Prince. He's the chairperson of RTAC. They are working with Dr. Schenker and other members of the REMAC to create a tag that is going to be, where is it? Working to evaluate regional trauma system issues. It's working, I believe, in concert or because of whatever's going up at the Cmac level. or the state level with regards to evaluation of statewide trauma centers. So they're trying to do it here on the city level. And we will be able to give you more information at the next meeting. If anybody's interested in joining, just email me.
Yeah, hey, Marie.
Doug?
Yeah, I just want to bring up a point, because I do attend every RTAC meeting. So I'm not sure at the state, the state level, if you, Marie, or Art could bring that up. But in terms of when I present at RTAC, there's a lot of people who complain about EMS. And we're a major problem in terms of the level of trauma care in the city. And what I point out to members of RTAC, it's not so much EMS. I said they need to look within the system because you have a lot of these different systems within the systems and they don't communicate. So, the big hospital system are groups now. So one of the two things that was suggested to them, one was what we've done, and we've laid a foundation using the First Watch program for stemming stroke. With that foundation, I said, let's do the same thing with trauma centers because there is a disconnect pre-hospital and hospital in terms of data and outcomes, and that's something we all starve for. So I did have Todd Stout present at 2 meetings ago at RTAC to the committee, and it's actually very reasonable. There's funding sources and everything else, and I pushed RTAC I've been pushing them for 5 years for something like this, and there still hasn't been movement on that. The only thing I get follow-up with certain trauma surgeons that want to do their own little personal projects. And I said, we need to look at it from a system standpoint. The other thing was I agree communications within the system, certainly with the pandemic and everything else that, that's a fair comment. One of the things that if Brad's still on the phone, on the call here, we did have a presentation by Jenna from Greater New York Hospital Association on SITSTAT as well. And to try to get buy-in from trauma centers and so on, from a system standpoint in terms of communication. So, we have some low-hanging fruit that's been offered to the trauma community to help improve the system. We need data to help drive, to help make improvements. Also, we need to improve a bit on our communications. So I do want to strongly encourage, and I will bring this up again at RTAC and keep, I've been saying the same thing for many years there, but there's simple things we can do to improve the trauma system that we currently have. So I just want to bring that up because I don't think everyone's listening to that on the trauma community at RTAC.
Okay, well, I would suggest that you join this tag because we already have Greater New York on board with it. We haven't had our first meeting yet, but there is participation on the RTAC side and the REMAC side.
Yeah. I just want to bring that up, Marie, that we have from a REMAC standpoint, from the city and other, we have been pushing, making suggestions, trying to improve the system that we currently have. So I just want to bring that up to everyone, make them aware.
Okay.
All right, thanks, Doug. Regional Council update.
Okay, so REMSCO met on April 27, 2021. The following is a very brief summary. There were 3 applications for transfer of operating authority from ACE to AMR, from Hunter Ambulance to GMR, which is AMR, and from Hunter EMS to GMR, which is also AMR. They were all deemed complete. REMSCO will vote on them at its next meeting, June 29th. There was an application of an expansion of Bay Community Volunteer Ambulance Corps. It was deemed complete. A public hearing was held May 26th. Now, we have not yet received the report from the hearing officer, but we intend to vote hopefully on June 29th. There was a mutual aid agreement with New York City Emergency Management to expand the territories of all VACs to help support COVID initiatives in New York City. Next REMSCO meeting will be held June 29th, 2021. That's it.
I just want to add to that. Yep. New York City Emergency Management has extended our mutual aid expansion until the end of July so that we can continue doing this until the city winds down its COVID initiative. That's it.
Thank you. Okay. Next is Cmac update. I don't know, several of us were there, but Dr. Marshall, do you want to give a brief summary? Can you?
Yes, I'm here. Briefly, the New York City protocols were the only one an action item and they were approved. End of my report.
You cut out, Dr. Marshall.
You cut out, but
Okay.
the New York City protocols were kind of the only action item.
Okay.
Yes, that was the only action item and it was approved at Cmac and REMSCO. Yeah, that was it. There's something else, but I can't remember right now. No action items though.
All right.
But I'll check the
I don't
minutes and
recall
get it
any
to
other
me.
action items either. Yeah.
Yeah.
I think there was some discussion about the letter that the Hudson Valley region received from the state regarding their authority in approving ALS upgrades. And there were some questions around that about what authority the Bureau had versus the REMAC. And I think it was more about their process than the actual who has what authority. But that was the only other discussion item I recall.
Yes,
Yeah.
I think so.
Can I add to that? I've had the State Department of Health actually asking me what we do and do we think we really have authority to do this? And I know that we have authority to do this. So I just want to give you all a heads up that we might have to fight for our rights, the rights of our physicians to oversee our EMS system. This new administration in Albany seems to want to centralize all the power into their office and not allow us to make any decisions on our own. So be prepared.
Marie and I just like would add on that we have to make sure, that people representing our region that, as a committee, there was a majority supported that we have our unified protocols, and we got to make sure that's the message that comes from our region and not anything different.
Yeah, absolutely.
Okay. Thank you. Now it sounds like there are mixed messages sometimes going up there. So.
All right. Any unfinished business? Is there any new business that anyone wants to bring up? No new business from anyone?
Oh, actually, the new dates. I was asked to try and set up dates in September for REMAC, and I have a tentative date of Thursday, September 9th. So look in your calendars and get back to me if this is a bad date for you, because we usually have our meetings on Tuesdays. It's going to be Zoom, so it should be easy to attend. Our chairs think it's important that we have our meetings. And those are the dates that don't conflict, I think, with all the Jewish holidays.
Okay, and Marie, any update on when we might have a return of in-person meetings, at least for committee members?
I have in-person rooms set up starting in October. So,
Great.
Yeah, I just have to figure out the technology on how I'm going to have in-person people and then be able to stream to everybody else. And that we'll figure out over the summertime, but I've gotten rooms already for members only.
I believe Ben has his hand raised.
Yes, Ben, go ahead, please.
Not to turn it into a whole big thing, but I know there's been a couple of meetings about this Maru application. And my understanding from these meetings is, as of right now, the application has not been officially selected or endorsed as being, it's individual providers are signing up for it and individual agencies maybe, but there's not a unified, this is what our region is doing, or people are required to use it. And there may be some confusion amongst providers that they are, if they're using this app or any other app to calculate drug dosages or other things, the provider is, the one as of right now who's responsible for the accuracy of the dosage they're giving, the formulation. And I wonder if people feel like we should put something out as a region that, as of right now, that even though the state is saying this is the app to use for the state protocol, that people should be aware that any app they're using, the provider is still ultimately responsible for their protocols, their decisions, their dosages. Just bringing that up.
I think we really do need to make a statement, because the state is making it very clear, and the company is making it very clear that this is the capital THE approved app in New York State. So if we want to unapprove it in New York City, we better make that clear because they're doing a lot of advertising.
I'm not suggesting we unapprove it, but I'm saying the state has done a process where they've selected that as the state app for the state protocols. You know, as far as I know, there was not a competitive process at the local level. I think some people have concerns about it's a ultimately for-profit application where, you know, agencies or providers will at some point have to pay for these functionalities that right now is free. And I think there's some confusion that something that's been selected by the state as the means of accessing the state protocols does not necessarily mean it's had that same stamp of approval at the regional level, at least as of right now.
I think you're right. That's exactly what I'm saying. I agree with that.
No.
Yep. Marie, go ahead, Marie.
Okay.
Marie, and then
We've been working with the state and our agencies are using this. There is, this is more of an administrative decision to use a program. There are plenty of programs out there that we haven't approved that are out there for years. Our board of directors tried to create a program several years ago and it just never came to fruition. Now we have a free program that is going to be identifying our protocols as we write them with no changes. And I don't understand why we wouldn't want to put this tool into the hands of our providers. We're creating these artificial barriers and I don't understand why. This does not remove control of protocol development from the physicians. It's just giving our providers another way to access them.
Tony, then Doug, then Nathan.
Dealing with this anymore.
Yes, thank you. I agree 100% with Marie. I think it's a good application, and I think we should encourage our providers to use it. And I think there's no reason not to make an official statement. I mean, the state did, and the trauma services did. I don't see why we wouldn't. And just one question on it, because I missed that meeting. When is it actually updated? When the commissioner, when it gets through Cmac, when it gets through REMAC, when is it actually put into the program, a change in protocol along the process? I don't know if they addressed that at the meeting, because I missed that meeting.
Well, Muru will wait for us. They don't put our protocols up until we tell them this is the final version and we're implementing on such and such a date. And that's when they will activate them.
Oh, okay.
The same way that I would be putting them on our website.
Right.
There's no
Great.
difference
Thank you.
except it's on a phone instead of on our computer.
Thank you.
Doug, go ahead.
Yeah, and I just want to add my 2 cents or 1 cent here. Listen, I think there's a lot we're still learning about Muru. I think, Stephen's done a very nice job presenting the app. I think it's very useful, but, I think a lot of us still doing our due diligence. But Maria, as you said, there are a lot of different apps out there. And, ultimately, this is a for-profit company. And you still have to pay a fee when the services, except for, the basic functionality that Stephen's offering through the cap, when the for free stuff goes away after whenever that's determined, whether in the year, what have you, there is a real cost and significant cost. So that being said, since this is for business, I don't think this committee should be recommending, I think if that's what you said, Marie, any particular app, because there's a lot of things that are coming on the market. There are a lot of things out there. And so you have to leave it to individuals who want to pay out of pocket. There's no reason why any personnel can't download this app onto their personal phones. But then allow for respective agencies from an administrator's standpoint decide whether to use such an app and any potential other issues around it. So I don't think we should be endorsing any particular app personally, as there are a lot of other things that are available now or are becoming available. So.
Well, from what I understand, this.
Oh,
sorry, this app is free for individual providers. If an agency wants to get additional functions, it's up to the agency to decide whether or not to accept it or not. So,
Marie, a lot of this stuff goes away. The free stuff goes away. Just the basic stuff of having PDFs and access to protocols, but all the other functionality that is available, and there's some very good functions. At some point, and I know I saw Stephen on the call. Certainly, he could speak up on that. But eventually, that free part goes away, and then there's real cost to individuals. So. If people choose to use it, that's fine. I mean, that's just, but I think the other issues surrounding the other, just like equipment, REMAC shouldn't dictate, what video laryngoscopy device or laryngoscopy device, whatever people use, that's up to respective agencies. I think it's the same thing as another instrument.
Nathan, did you want to make a comment? I saw you had your hand up.
Excuse me?
No, just
I see.
I just think we should be endorsing that any specific app, and I don't think the REMAC should put our endorsement on any commercial app.
Thanks. Jonathan?
Thank you for recognizing me. I just wanted to say that aside from, I don't believe we should be endorsing any app. There were some concerns that can cause provider confusion as they crowdsourced information about what equipment an agency specifically uses, and that can cause some confusion between the providers, especially when it doesn't come from the agency itself. Thank you.
Tony?
Yeah, I still think it's a good app, and I think we should encourage people to use it. Some students rotate through telemetry, and they ask me, "Was it REMAC approved? Is it REMAC approved?" I say, "Well, not really, but a lot of people use it, and a lot of people like it." So the medics, they're concerned they don't want to use something unless it's REMAC approved. So I think we could put a generics thing out. Like we always say, like defibrillators have to have these capabilities, or this machine has to have these capabilities. We can say, not to say you're endorsing this particular capital, project, money project. We could say if it's current and it meets its current protocols, you could use it. And generically, you could use any of 15 different apps to use. But I do think we need a statement saying that you can use an app if it's blah blah blah. And that would cover it, rather than say, no, we're not endorsing anything. I don't think that's more reasonable to, but yeah.
Yeah, and to Doug's point, that has been our policy. We don't, when it comes to anything, defibrillators, airway, like laryngoscopes, there's no specific, we don't do product endorsements. So, I think if we had a generic statement about use of apps in general, it would be fine, but I don't, I agree, we don't really we're not in the endorsement business. Anyone else?
Hi, it's Brad. So can we make a motion to do what I think everybody's saying, is to say that, there are apps out there, the REMAC does not endorse any specific app and so on.
Would you do that as a REMAC advisory? Is that what you're proposing, that we send that out?
Yes, motion we send a REMAC advisory.
And to addend Brad's motion, which I second, but I would consider putting something in there that says something to the effect that, the REMAC is not validating the accuracy of any particular app, and it's incumbent on the provider to, check, to know their dosages and to check the math, and
that's a friendly
without
amendment.
singling out any particular app.
No amendment is friendly. You taught me that.
Yes.
Marie, do you want to make a comment?
I don't think that we should do anything to prevent people or frighten our providers from using these devices. We don't have to specifically name an app. We just have to say that, these applications have the current New York City protocols on them.
But I don't think that unless we've gone through and we've checked that, because it's not just linking to a PDF of the protocol, it's taking that protocol and doing calculations on it. And I think similarly to if I'm in the ER and I want to use an app, and I have no relationship to any apps, but I want to use something like PDStat to calculate the pediatric drug dosage, I'm responsible for any errors that I, have to sort of double check and know roughly what the dose of Tylenol should be, because I can't just say, well, the app told me to do it. So unless there's some process that which the REMAC checks particular apps and validates that they're accurate, I don't think that the REMAC should say, yeah, this is an accurate app. I think it's on the provider to, they're ultimately responsible for the treatment they give. And they're welcome to use an app, but they're responsible.
Right.
Well, the only thing that we can validate are the protocols. Yeah, we could just validate the protocol, not the.
But I don't think it's our role as of right now to validate apps, because then you have to validate any app that uses our protocol.
Thank you. Dr. Cooper, and then Yadidja.
Thanks, guys. this is as much a legal issue as anything. I would suggest we get a legal opinion as to what the extent of our liability might be. I agree with Tony and Marie that anything that gets accurate information out there, will be helpful. But I do think there are legitimate issues to be raised in terms of potential legal liability, how far that would extend, and so on. I would really strongly recommend we get a legal opinion. We have a counsel to the to REMSCO and REMAC, and I think that this would be a good issue to bring to their attention. Thank you.
Dr. Langsam.
So about an hour ago, I want to remind you that you just voted to remove from length-based guides all the dosages and just to let them use it just for weight and calculations, but not for dosage calculations. This is no different. I agree. If you don't want to trust the Braslov tape, for example, then why should you trust this app for the dosage calculations? So it's the same thing we did before. We did it an hour ago. We took it away because we didn't want to endorse the way the length-based calculations were done. Electronic paper makes no difference. So I agree. We should make sure not to endorse this. What the state does, they don't listen to us anyway. They do what they want. But we should not take this responsibility.
Okay. Doug.
Yeah, listen, because, I see, there's a few people that seem unhappy with the conversation, but there's no reason why now, especially while it's free, that people are going to use it on their personal phones. So, that's up to individual members. So if we're not for now endorsing and I think, maybe I think Marie had asked about, because I'd want to start a committee or whatever you want to call it on dealing with technology related stuff. Maybe this could be the first project that we take up and if we need to draft language, generic language in general with any app-based programs that someone can look at and come up with something. I think it maybe needs to be addressed in some form, whether it's something, a document just released, by REMAC, but, for now, there's no reason why anyone who chooses to use it, just, I think Ben, articulate, they kind of use that your will, like with anything else, but just you have to be protocol. So if people want to put on their private phones, that's up to them.
Right. Pesach, and then I have an idea for what we can do with this, but Pesach, go ahead.
Just to speak to some of the concerns that were mentioned recently, and I'll tell you, I have personally been using this app for a couple of months in my daily practice, and I have come onto some errors in their calculations in some points, or in their representation of the protocol, the way they summarize it in their when they feed it to you. And I have addressed those with them, and sometimes they're fixed quickly, sometimes not so quickly. But there are errors that it's inherent. There's going to be typos. We sometimes have typos with incorrect information when we print our protocols. And the difference is who's taking responsibility for it. With them, they are not willing to say that they accept responsibility for an error that occurs. They're just saying that they have a robust process to hopefully prevent errors from being there in the first place. And it's incumbent on me as a provider, when I use it, it's a great resource and it's helpful. It helps me, zero in on something, and then I can go back and click the button to view the PDF version and make sure that it's all accurate. But I have to know that I have to do that, and that's my responsibility. And I think that's what people here several people have been mentioning. It's not perfect. And I think we should make everyone aware of that, at the end of the day, the responsibility is still with the provider.
We have Steve Blocker here, and I think that he should be given the opportunity to respond to some of these questions.
Yep. So I'm going to let Steve speak, and then we're going to wrap it up, and we'll decide how to proceed forward. But Steve, please go ahead, and you can address whatever you'd like that's been said.
Great, thank you. Well, first, thanks for all of you taking so much time to discuss us and taking all the time to vet the app. I really appreciate you putting in this much time to it. To talk about your concerns, the way we came up with the relationship with the state and the way we're doing all this is we want to be working directly with you. If you had privately funded a product with the money that you raised for the region and went to purchase something, right, you would state the specifications of what you would want. and go through all the details in vetting the product. We do not want to do anything out of line from what you guys would like your protocols to say. And we don't want to do anything different than how you would like it executed. When problems are brought to us, we are immediately attempting to fix them as fast as we can if there's anything off. And if you really want the max amount of technology used to help your providers access the stuff that you're spending tons of time working on, we want to have this relationship to be able to work directly with you and ask you questions before the protocols are published, get the answers out and have it vetted before the protocols are published, and making sure that we can be the best megaphone you guys have for getting your information out there. To make sure that when you talk about endorsement or things like that, our entire purpose is to say that there is a product, no matter what, that every provider can access for free. Meaning that if they want fancy extras, if you want to call them that, like dosing calculators or training insights, that is an extra piece. But if they want access to what you guys have spent so much time working on and making sure that when you have a push notification, when you have something changed, it immediately pings every provider's phone. The best way to do that is to have a relationship that says, yes, we're taking a lot of time to work with this product. The fact that we are not personally charging you money, right, shouldn't be the difference between endorsement and not. Think about it as the state has purchased a tool for you and that we want to work with you to get it done, right? There is as you've seen from all the meetings that I've been attending, right, at anyone's request in New York City, we are making ourselves completely open book and having conversations with anyone who wants it. So as you think about where to move forward with Muru, we're happy to work with you in any way you guys choose, but I would just say that we are opening our doors as providers from New York State who built this thing from scratch to say we are only here to help get the information out. And if you want to create more distance between us and you, then that's your decision. But I think it would be better to go the other way and say, please vet us as much as you want. Dr. Lai, a whole bunch of other Dr. Isaacs have brought up concerns that we're actively working on to try and resolve already in the system. And we're going to continue to work with you as best as we can. If we can't get access to have the conversations, if we can't get the meetings, and if you don't help providers get on the platform, it will be half as powerful a tool for you as it will be if we are working together on it. And to that end, we are always creating and keeping a free product out there so that all providers can have it no matter what their financial point of view. As far as the for-profit thing is, yes, we are a company, and yes, we have to keep the lights on, and yes, we have to build a product that can, generate enough revenue to keep building really great and exciting technology for the providers to use. But that's how a business runs, right? And so as much as I'd like to say it's free forever, we do not have benefactors who can foot the bill needed to create this level of advanced technology. So we are trying to create the best blend of those two items. So if there are other products out there, as a provider in the region, I've been aware of very few, especially none that have invested this much time and energy into bringing this product to market publicly for everyone to have access to. We've been free for 1.5 years, no matter what level you wanted. So, we're really, really happy to work with you. And again, we really want you to take the time and energy to tell us what you want fixed, and we'll fix it, right? There's really nothing we're not open to having the conversation about and really being your tool. So that's it.
Thanks, Steve. So if I can make a suggestion, Brad, it was your original motion, so I'll ask you your opinion on this. But seeing as the chair of REMAC is not here tonight, and I don't have the power to appoint a committee, only the chair does, what I'd like to do is if we could table this, bring it to the executive committee to talk about putting together over the summer a technology tag group with the executive committee to work on some language, because currently we're kind of mute on the whole point of apps. We don't make any statement about any apps currently. So, I don't think there's any reason to rush into making a statement. I think we should take some time, work on, with the involved people in a technology group as to what do we want to say about apps in general, and then maybe put out something, speaking about the use of apps, in EMS in the region. Would that be acceptable to you, Brad, or do you want to proceed with a motion?
My only concern is, and I think that we should definitely continue to look at it and put out something in the future, but there's a lot going out right now. And as Tony said, people are already asking. So putting out a statement that I think everybody's kind of saying the same thing. One, that apps may be useful. Two is that the REMAC is not endorsing any particular app. And three, that the provider is ultimately responsible, I think is a pretty reasonable statement to put out. I don't think we should be waiting months. And then we could certainly amend that, and we should talk and amend it. But I think that motion still stands as a reasonable motion.
Okay. Well, I think the three things you just said are very reasonable suggestions. Is there a second for that motion?
Yeah, I second it, Lou Marshall.
Okay. Any further discussion on this? I know we've discussed a lot. If not, let's take a vote. Go ahead.
Jack, can we just clearly restate the motion, please?
Yes, you did. You had a comment first. Yeah.
I'm just asking Lou, does the board of directors, I'm not talking about REMAC REMSCO, but the board of directors of the whole shebang have anything to say about apps and endorsements and things of that type? I'm just asking. I'm asking Lou.
Well, we, as has been said by many, we refrain from endorsing any technology specifically related to anything that we do. So the board, I'm sure, would go along with that as well. The statements that Brad has brought up, I think, are reasonable for the immediate time frame, and we can work on them going forward over the summer.
Thanks, Lou. Brad, would you just restate it for everyone?
Yeah, and I wrote down, I'm glad to work with you. The 3 points. The motion is to put out a REMAC advisory that includes the 3 points. One, that smartphone apps may be a useful tool for providers. 2 is that the REMAC does not endorse any particular application. And 3, the point is that the provider is ultimately responsible for being in compliance with the protocols.
I second that.
Okay. If there's any further discussion on that. All right. We don't need a roll call vote for this, right? It's not a protocol, or do we?
You don't.
Just a general.
No.
Is anyone opposed? We'll do it this way. Is anyone opposed to that being issued? And with the understanding that we're going to continue to look at it further over the summer, and hopefully appoint a technology tag group if it hasn't been done already to help with this. I know Doug was interested in that, and some other people. And so anyone opposed to putting this out now, as Brad stated? All right, great. So we'll do that. Doug, did you want to say? So you look like you wanted to say something. Are you good?
No, I'm good. Sorry.
Okay, that's all right. Yep. Anyone else have any other new business? All right. Seeing none, I will entertain a motion to adjourn.
So moved.
Okay. Thank you all. Have a great
Bye,
summer.
everyone.
Have a great summer, everybody.
Yeah.
You too, guys. Bye-bye.
Good job. Thank you.
Be well all. Have a good day.
Bye, everyone.